Okay, welcome back. So I hope you all enjoyed that first session on communication. And we now move on to what a family member can do in terms of caring for a loved one with schizophrenia psychosis when their insight is reduced and they don't seem to realize there's anything wrong or that anything in particular needs to be done. So, how can you care for a loved one in that difficult position? So, what are the main points we're going to be discussing and thinking about here? Well, the first question is, what is insight? This is a bit of knowledge we need so that we can understand what is happening in the caring situation when insight is impaired. The next question is loss of insight static or does it fluctuate from day to day and week to week? And what happens over the medium term, over a number of years? What happens to insight over time? The next question is, if we are trying to care for a loved one with poor insight, can we set any kind of goals? Now, this might be a goal that we don't think is a very good goal, but it seems crucial to set some kind of goal that we can work on together. Now, this might be an emotional goal, or it might be a behavioral goal. And it might be one we can collaborate on and decide on together. But with total loss of insight, they might not agree to going for any goals. So what would we do then? Well, what questions might we ask? What strategies might we employ in the complete absence of insight? So we're going to talk a bit about how we would try to interact in that setting. We're going to talk a bit about imagery, which can be useful when there's no insight. And then we're going to end up talking about the relationship between insight and sadness. And we obviously want to prevent any kind of self-harm. So it's to know what to do if insight is changing. So first of all, what is insight? And this is the subject of tremendous debate in the scientific literature. So I'm going to summarize it for you here. Now, insight in relation to schizophrenia psychosis is awareness of one's own mental condition. So the questions to be asked here in relation to your loved one is your loved one aware of mental phenomena that other people observe and seem to find unusual? That these might be things such as the mood being incongruous, for example, inappropriate laughter, a reduction in self-care that other people are noticing, perhaps hallucinatory behavior, sitting with the television muted, listening to different voices in the room. Or maybe grandiose beliefs that they are a very powerful spiritual being, or that they're about to receive all the money for all the hit records and songs that they've written. So are they aware that these changes in their mental condition, that other people are noticing them as unusual? The next bit is, does the loved one accept that these are abnormal to some degree? Because if they don't, why would they want to do anything about them? These changes in mental condition, does the loved one accept that these are due to a mental illness or a mental disorder of some kind? Next, does the loved one accept that these symptoms might need some kind of treatment, be it medication, counselling, talking therapy, rehabilitation? Does it need something doing? Now, one of the main things about this is that there is no actual brain damage in loss of insight. The loss of insight in schizophrenia psychosis seems to be due to a change in the frontal regions of the brain where changes are happening as psychosis develops. So something happens in the frontal and prefrontal regions to lose touch with the reality of the mental change. But there's no actual damage to the brain. So insight runs on a number of different rail tracks, and you can be at different levels on each of those rail tracks. So for example, you may realize you hear voices that other people don't hear, but be absolutely adamant that there's no mental disorder and that treatment is utterly unnecessary. Or, surprisingly, you may not accept you have a mental disorder at all, but be quite happy to take medication. So there's different parameters of insight, and we need to work out for our loved ones where they are on these different parameters, because this is an important issue. Now, we have to approach the issue of anosognosia, which is a big component of the LEAP training. Now, anosognosia is probably on a spectrum with the kind of loss of insight we see in schizophrenia. But I want to say some things about it because I don't think it's exactly the same thing. So, anosognosia originally was diagnosed as a self-awareness disorder in people with damage to the brain. Now, normally that brain damage is due to a stroke affecting the parietal region of the brain. So some damage there. It could arise with a tumor. And in anosognosia, this brain damage leads to failure to recognize the presence or severity of the result of the stroke. So everybody else can see that that arm can't move. The person with anosognosia, due to this parietal lobe damage, does not see that. They behave as if the arm is working normally, even though it's not. Now, interestingly, this commonly affects left hemiplegic limbs, so paralysis of the left limb with a right-sided parietal stroke, okay? It is almost unknown in the right side. So it's about the dominant hemisphere. It's just this particular bit of the brain which seems to be involved in this condition. Now, anosognosia immediately following a stroke is quite common, while the stroke is gradually picking up and resolving, and then it usually gets better. But sometimes if the stroke has affected that bit of the brain, anosognosia can be lifelong. And the person with the paralyzed arm will even go as far as to say, that's not my arm. That's why I'm not moving it. It's somebody else's. So they will try and explain their way out of it. So anosognosia is a different thing. It's in a different bit of the brain and it behaves differently. But I will accept it may be on a spectrum at the extreme organic end of the loss of insight that we see in schizophrenia psychosis. But that bit of brain damage is not there in schizophrenia psychosis. And maybe this means loss of insight would be expected to change. So, does it actually vary over time? Loss of insight is almost always present at the time of the first episode of schizophrenia psychosis. And loss of insight into the fact that this is a mental disorder is what distinguishes psychosis from neurosis. The person with anxiety disorder knows they're anxious. The person with OCD knows they're checking things all the time. The person with psychosis is hearing voices and doesn't really quite know what this is. That is, they don't have insight. So loss of insight is the commonest symptom in schizophrenia psychosis, and it occurs in 97% of those people who have a first episode breakdown. Hallucinations are the second commonest in 74%. Delusions come next in 70%. And then we have the negative symptoms, blunting of mood in 66%. So this is an incredibly common symptom. What happens over time if we just observe people? Well, insight tends to gradually improve over time. And it recovers in the same way that hallucinations and delusions gradually become a bit less troublesome as the years go by. So the majority of clients are not troubled by hallucinations, delusions, or loss of insight at 20 years follow-up. So there is hope that there's a natural tendency for insight to improve. But there is a thing called the insight paradox, which we'll come to. Now, this is a bit of research that I did in Newcastle with some of the Newcastle team there. And what we did was to take people with delusions, severe delusions, and we didn't treat them. And we just scored them every week for a period of 3 months. We went back and rated them because we wanted to know if Carol Jaspers was right. He said delusions are fixed, false beliefs, and they don't change, and they don't have insight. So you can't use evidence because they're fixed. Well, on these 4 patients, we saw massive variation in delusional intensity and in the amount of insight they had into the delusion. So if you look at the first blue line on the graph here, a family member living with this young man with this severe delusion, at the end of the first week, they're slightly more deluded, and it's going to be really quite difficult to have an interaction with them. And coming back 1 week later on the blue line, we've had really quite a big reduction in the intensity of the delusion and there's a bit of insight coming back there. So on the first occasion the family member saw them, it's incredibly difficult to get a word in or to have a meaningful discussion. The second time, it is much more possible to have a discussion about this delusion, how it's affecting them, what it feels like. But the next week, we've had a huge increase in delusional intensity, and insight is even less. Now, the question is why? And the answer is that people with psychosis and loss of insight are extremely sensitive to their environments, and their delusion and their level of insight fluctuate in terms of what's going on in their life. So this a chap who's gone up to a score of 10 on delusional intensity may have found that people have been confronting him about his delusion, telling him it's not true, and he's actually become more deluded and less insightful. So here we have a very interesting sequence of measures which show that some days it's easier to talk to people with severe delusions, and we should wait for that day and not do anything in the home environment which is causing these really big fluctuations. Perhaps, as in our previous session, due to a lot of emotion in the house, or perhaps what's happening in social media, what they're watching on television, etc. Now, it must be said that voices behave in a very similar way. So they're variable in terms of intensity and insight. Now, I think this is a hugely influential slide. The concept here is don't get down about loss of insight, just wait for a better day, and you will have chances to care more easily and make a bit of progress. So, what about therapy? Can therapy improve insight? The answer is yes. A number of different therapies can improve insight. And I mean, this is the tragedy that these therapies aren't available. So in the insight study, we trained mental health nurses to deliver just 6 sessions of CBT to the loved one with chronic schizophrenia. And we trained the main carer. So the family member got 3 sessions so that they understood what was happening in the therapy. Now, this meant the family member, instead of not having a clue what was going on, was part of the treatment team. The sessions of CBT were recorded, as long as the loved one was agreeable to this, and the family member would listen to the session and would know what the homework was and would know what they were meant to be doing. So the 6 sessions of CBT for people with chronic schizophrenia and the 3 for the family member led to significant insight improvement by the end of intervention. And there are a number of therapies which have shown insight improvement. And there were really 2 elements of insight improvement which correlated with the beginnings of recovery. So the first one was when the loved one started to understand that voices and delusions weren't out there. They weren't external. They're in here. They're part of them. Now, that insight really helped recovery. The next one was insight into the fact that medicines might be of benefit. And of benefit for various different parameters. But if they started to realize, yeah, I'll take that medicine. I can see the point in that, in this situation I'm in. That correlated with the beginnings of recovery. But here's the insight paradox. Those loved ones that discovered the insight that this was a mental disorder called schizophrenia tended to have the emergence of sadness and even clinical depression and a bit of a reduced quality of life. So the S word, the schizophrenia word, can be toxic if you come to realize that's what this is in the process of your recovery. That is the insight paradox. So there's the CBT, 6 sessions for the client, 3 for the family member. Family members knowing what to do, helping with homework, listening to the audio of the session. And what we see here is overall symptoms get a bit of improvement, but the biggest result here, and you know it's the biggest result because it's got 3 stars above it, the insight result was very highly significant. So even a small number of sessions can improve insight, and certain types of insight can lead on into recovery trajectory. We also saw improved depression with these sessions. But when we followed up, the insight paradox had kicked in, and some of those that had realized this was schizophrenia had become depressed. But interestingly, at follow-up, negative symptoms were dramatically improved. This is just a small pulse of therapy with a family member backing it up. So what actually did improve insight in this study? So we took feedback from the clients. This was a very big study. There was over 200 people with chronic schizophrenia who received this intervention. And we got feedback from them. And here's just some of the ideas that they said. Having regular contact to bounce ideas off was a good thing. Just to be able to talk about their psychosis. And one of the therapists was described as a sane reference point. Now, obviously, the therapists weren't allowed to confront or collude, but they had a dialogue about the psychosis. And this came up as something important, the fact that the psychosis could be spoken about openly without feeling confronted. Some people said asking questions about it, asking questions about voices and finding out more was useful. So it's breaking through the low insight to find out information about voice hearing, perhaps on the InterVoice website or on treatingpsychosis.com, or watching a TED Talk which talks about recovery. I will have a list of these useful resources at the very end of the day. Now, goal setting was mentioned as being important, but the clients were very clear it was not the therapist's goals, and it was not the family members' goals, it was their goals. And it seemed like starting to hit some of their goals, often not about psychosis. These were personal goals, allowed gradual goal setting, which took us towards psychosis and the chance to work there. They spoke about the ABC model. So we had one young man who believed that he'd written a whole number of famous songs by the Beatles and Michael Jackson, etc. And he was just waiting for all the royalties to come in. So that's the B, that's the belief. So we can say to him, what was the A? What was the activating event? How did you come to realize that you had written all this material? And this allows you to go back to see how this all started. So the A links to the B, and the fact that you believe you have written all this music seems to lead to a consequence, a C, that you're just sitting at home waiting and getting a bit frustrated that the royalties aren't being sent to you. Is that how this looks just now? And if we can agree that's how it looks, we can then start to look at the A or the C to see if they want to do anything to change any of it. So for some people, the ABC model was useful. In terms of the surprising finding that some people using CBT decided that medicine was a good idea, which I must say we weren't really expecting, it seemed to be this idea arising out of normalizing that medicine could be used for other things. So we had people agreeing to take medicine because they weren't sleeping well. They were sleep deprived, and that was worsening the psychosis. So they would eventually say, oh yeah, okay, I see that link. Sleep deprivation is not a good thing. So, okay, I'll take something to get asleep. Or they might say, well, my moods are all up and down. They're all over the place. So might they accept a medicine to stabilize mood? Now, obviously, the antipsychotics can be used for either of those things. And then they start to see a benefit in terms of the voices or the paranoia. So the different functions of medicine seem to be important, or that's what they told us. And we had a few people that were listing the pros and cons of medicine, and on looking at the pros and cons, decided that there was more pros than cons. Normalizing seemed to be useful because they didn't have insight into the fact this was a disorder. So coming from the normalizing direction, and we discussed this in the previous presentation, allows them to see from the normal perspective how things like bereavement, use of cannabis, excessive stress, trauma can lead to strange experiences. In relation to the insight paradox, it's important to decatastrophize the schizophrenia label. And we're normally saying to them, this is an older type word. We don't use it quite so much anymore. We're more referring to this as psychosis. And psychosis means you're experiencing some strange things and the mind's playing tricks, and psychosis can recover. Sometimes it's not easy when the loved one is talking a lot about psychotic material, or where they're just sitting in silence and not interacting with you at all. And the question is what to do in that setting. Now, what I do when I see somebody who's referred to me who is extremely delusional is I sit for brief periods of time with them and I absorb the psychosis. And the purpose of that is so that they begin to trust me, so that they know that despite the fact they're dominating the discussion, I'm going to keep coming back because I'm interested in their story and I'm interested in them. And as I keep coming back for these brief periods of time, they start to give me a chance to have a dialogue. So sometimes we need to just sit in, spend 10 or 15 minutes listening to it, maybe giving little bits of feedback along the way, and we will get a chance to start to understand what's going on. And I once described this as just letting the waves of psychosis roll over you. So you might need to do that for a bit, but don't spend too long doing that. 10 or 15 minutes is plenty. And just keep coming back from time to time, and you'll get a chance to understand more about it. Sometimes it's just silence. Sometimes they're not talking to us at all. And we can spend brief periods of time just with the silence, saying, hey, it's okay, I'm here. Let's just be silent for a bit of time. I know that you've got things in your mind, there's feelings there, there's stuff going on for you. And I'm here, and we're just going to be silent for a bit. And you just let me know if there's anything I can do that might be useful. And as in the person who has lots of psychosis they want to tell you about, the person who is silent will also start to build up trust and will start to tell you about their inner world. Can we set any kind of goals? Now, it seems to be we do need to, and the purpose of what we're doing in coming back regularly and building up trust is so that we can try and get some minimal personal goals. Because what we want is a success experience. We want something to start to move in the right direction. So is there anything we can talk about? And it doesn't matter what it is. It can be the ice hockey scores. It can be anything. If we can't talk about anything, is there an emotion there? Are you feeling anger with the world or with me? Are you feeling anxiety? Or are you feeling sad? You can then cut through this and say, you actually seem a bit more anxious today. Am I getting that right? And I mean, that's very understandable. We don't need to talk about this. But is there any way we could help this anxiety? Could we score it? Today, I'm feeling about 40% anxious. If 0 is totally relaxed and 10 is panic, today I'm about a 4. Can you give me a feel for what you are? You might get some fingers held up. They might say, oh, I'm fine. Or I'm an 8. Get something back, get a score on it. Okay, so now we're into a possible personal goal. Would it be good to reduce that anxiety a bit? Would you want that to happen? I wonder how we might do it. Is there anything you've found relaxing in the past? Because that's a good way in. And if they don't come up with anything, let's put on some relaxing music. Maybe some jazz, something that we can listen to the lyrics on. Can you suggest some kind of music that might be good? We'll put it on together, we'll put it in the background, and we'll just see if we feel a bit less anxious in 20 minutes' time. I'll come back and see you then, and we'll see what's happened to the anxiety. Now, these are the roots of beginning to set goals with the person with very low insight. And if we can get a little success there, we can then start to slowly build on that. And we would quite like to get next onto behavioral goals. So, hey, that was quite good the other day. We both felt a bit more relaxed when we listened to that music. Is there anything we would like to try today? Success breeds success. I mean, you've not been out of the house for a long time now. How about we try and make contact with one of your old friends? Maybe just a phone call. Or how about getting a girlfriend? This seems like a long way away, but it's an idea. And our ideas can just get knocked down. That's okay. Or how about getting a pet? We used to have a dog and you loved that dog. Or how about getting some more money? Are any of these kind of good ideas for thinking about? And very often the key point is which is the easiest to do, because in the midst of a psychosis with positive and negative symptoms, getting a girlfriend is out the ballpark. That's not going to happen. But maybe putting the lottery on and choosing the numbers and seeing if you win is much more accessible. And maybe if we did that and we won nothing, it's at least something we've shared together, and maybe we try to reduce anxiety again, and then maybe we think, what about a pet? I mean, could we get the neighbour's dog to come in and see you for 10 minutes? What do you think about that one? Need to make sure it's a friendly dog, but maybe that dog could come in and see how the loved one interacts with the dog. These are all small mini successes in terms of setting goals and achieving them. And it's that very, very slow trajectory that we need. Sometimes we're just not communicating. And we can use questions to try and break that up. What's it like being here in this room with me and not knowing what to say? Are you thinking about something you might want to say to me? Or is your mind empty? Have I done something to upset you? And then the move into images. Is it like walking through mud these days, trying to find some words? Can you see that mud? How deep is it? Do you have a picture of it in your mind? What's that mud all about? And then you might get some kind of conversation through the image. Does this seem like swimming against the tide? How much effort are you putting in to keep yourself afloat here? Can you see an image of that river in your mind? And the loved one says, it's an absolute torrent that I'm swimming against just now. It is just so hard to stay afloat. And then you have the beginnings of discussion. Is there anything I can do to help you stay afloat? What might that be? And then we can think, is it to get the anxiety down a bit? Is it to take the pressure off? What is it that we can do? Sometimes we want to talk, and at the very same time, we don't want to talk. Is it a bit like that? Maybe we can just sit with that for a minute. I mean, that's the difficult thing, isn't it? Is there a thought about that being stuck? Or is there a picture in your mind? And the loved one might say it's like trying to break through a wall to the other side. They might give you some image of this, and then that might allow you to understand what the breaking through of the wall is all about. It might be based in psychosis, it might be based in stigma, it might be based on the levels of emotion in the house. It could be a whole bunch of different things, but we need a starting point to try to work together so that insight might start to change. Now, we've considered the issue of medicines. Basically, the antipsychotics are tranquilizing medicines, the major tranquilizers, Some of them block dopamine receptors, some of them don't. So that they're basically a tranquilizing group of medicines. And what about treating your sleep problem? Almost everybody with schizophrenia psychosis is sleep deprived, or they're oversleeping, which has an equally negative effect on their psychosis. So could we try this medicine to get you better sleep? We know that these medicines protect the brain from excessive stress. So could we use it to keep your stress levels down when you're going to see that neighbour's dog tomorrow? Or when you're trying to deal with these voices that you've started to tell me about? Could it make you feel a bit calmer in the face of this belief that there are people out there who want to hurt you? Because in the face of that belief, we need to be calm enough that we can think straight. These types of medicines can also reduce anxiety and prevent depression. Some of our loved ones have mood swings. These medicines can stabilize mood. Would you want a medicine for any of these targets? So a number of people in the INSIGHT study did take medicines for these various targets and found beneficial effects on their voices and paranoia. And I think it's really important that if the medicines are rejected, as long as it's safe and with no insight, taking a tranquilizing medicine just does not make sense. Okay, so is there any role for something different? We know that you're really stressed out just now. We know that there's anxiety there, you've told me that. What about some CBD oil? Would that be worth trying to try and settle and see if it helps a bit? We know that melatonin can help regularize sleep. Would that be worth a try? There's a literature around fish oils and taking fish oils to help with psychosis. In actual fact, the doses needed are very high, but experimenting with fish oils is reasonable. Some people might want to use complementary medicine type approaches, such as magnets. I remember one study where we tested coping strategies against a placebo, and the placebo was a bracelet. And almost all the clients in the trial chose to keep the bracelet rather than the coping strategy. So we've got to realize there's a big placebo effect in schizophrenia. If the loved one wants to try something, if they have no insight and it's safe to do so, let's try it. But let's try and score the before and after so that we know if it works. So you want to try a magnet. Okay, how do we get it? What does it cost? How do you use it? Let's find out the details of this. And this is all scientific inquiry. We're teaching the scientific method. So what does it treat? It makes you more relaxed. Okay, we get the magnet. Before we score the anxiety, after we score the anxiety. If it's working, if it's helping, great. We keep it going a bit longer. They usually don't have a durable effect. But what we can do is say, okay, we've tested that one. Will we try something else now? And we might work towards a tranquilizing medicine, having scientifically tested these other ones and found them not to be working that well. The loved one might say, okay, we'll try that. We'll try a syrup, we'll try something that I can swallow easily and we'll give it a week and we'll see what it does. So insight, sadness, and self-harm, and this is the insight paradox. A patient once said to me, one day I was king of Europe and the next a patient in a ward with schizophrenia. Now this was somebody whose insight had suddenly improved. It was an insight jump, and this was due to effective treatment with medication. And he became very, very depressed. And you can almost feel his pain in that statement, from the grandiose delusion to being a normal human person with an illness which is heavily stigmatized. So recovery of insight along this parameter can bring with it sadness, even depression, and thoughts of wanting to hurt the self or even suicidal ideas. So I'm normally not using the schizophrenia label or the schizoaffective label, though that's probably less stigmatized. I'm normally saying this is psychosis with mood swings, or psychosis with voices or paranoia. And this condition we expect to recover. Obviously, the degree of recovery is individual. It depends on a lot of different factors, but we're expecting it to get better and to get a quality of life back. I mentioned reviewing stories of recovery. They're on treatingpsychosis.com, paranoidthoughts.com. Eleanor Longden's TED Talk is a brilliant story of recovery. Hope is very important. We need to stay hopeful and we need to generate hope in our loved one. And if there is any sign of the insight paradox, of that sadness emerging, we're going to ask for professional help from the psychiatric social worker, your psychiatrist, whoever it is you're in contact with, from your mental health team. So we're going to have a question and answer session about this. And first of all, I want to do this exercise based on this presentation. Consider your loved one's profile in relation to each of the 3 dimensions of insight. Now, your chances of getting a success experience will be easier with the parameter which is least affected. So they've got a bit of insight into the voices, but not on mental disorder or medication. We'll try to do a bit more in the voices, but we need to get that scoring, that understanding of the parameters. We then generate ideas from this session as how we might to begin to work with our loved one who has a loss of insight. Now, these are 2 books which are highly pertinent to this video presentation. Now, the previous one on communication is a big subject. Some of the communication stuff is addressed here. The first book was published in 2009, Back to Life, Back to Normality, and the cunningly named Back to Life, Back to Normality Volume 2 brings in a whole group of new ideas which can help us to work with CBT informed caring. These books are written for families with loved ones with schizophrenia, other psychoses, and are full of useful information.